Welcome to this deep dive. It's designed just for you, the learner, aiming to get you up to speed on coeliac disease quickly and thoroughly.
Yeah, we're going to cut through the noise, really focus on the key knowledge you need, and hopefully make it stick.
So the plan is a structured look at coeliac disease, what it is, causes, symptoms, diagnosis, management, the whole picture.
Exactly. We'll try and make it really clear. Maybe use a few memory aids along the way. Okay, so where do we start? Definition.
Sounds good. Okay, coeliac disease, what is it fundamentally?
Right, so it's a chronic, long-term autoimmune disorder. The key thing is it's triggered by eating gluten.
Gluten, that's the protein in wheat, barley, rye.
Precisely. And in coeliac disease, your immune system, instead of just ignoring gluten, reacts against your own body tissues when you eat it.
So it attacks itself where?
It primarily attacks the lining of the small intestine. This leads to damage, inflammation, and crucially, problems absorbing nutrients from your food. That's called malabsorption.
Okay, so the immune system gets confused by gluten and damages the gut lining. Got it.
Yeah, and it's this immune-mediated, gluten-sensitive thing. Affects about, 1% of people here in the UK, roughly?
And repeated exposure, eating gluten again and again, that causes ongoing damage.
It does. It leads to something called villous atrophy. Those little finger-like projections in your gut, the villi, that absorb nutrients, they get flattened and damaged.
Yes, surface area less absorption.
Yeah.
Makes sense.
Exactly. And it's often linked with other conditions too, like dermatitis, herpetiformis, that's an itchy skin rash, and other autoimmune diseases.
And there's a genetic component, right? I remember reading about specific genes.
Oh, absolutely. A really strong genetic link. Most people with coeliac, like 95%, have a gene called HLA-DQ2, and a large chunk, maybe 80%, have HLA-DQ8. Having these genes doesn't guarantee you'll get it, but it significantly increases your risk.
Right, so it's like a predisposition. Okay, that covers the what. Let's talk about the why, the etiology, the causes.
It's basically a mix, Genetics plus environment. We've mentioned the genes HLA-DQ2 and DQ8 make you susceptible.
The loaded gun, as it were.
Yeah, you could say that. But the gun needs a trigger. And that trigger is gluten exposure. You need to eat gluten for the disease process to start.
But just having the genes and eating gluten isn't always enough, is it? Or do we know exactly what kicks it off?
That's the million-dollar question, really. We know gluten is necessary, but the exact event, the specific thing that tells the immune system in a susceptible person, right, attack now, that's still under investigation. It's complex.
Okay. So given that, who's actually more likely to develop it? What are the risk factors?
Well, number one is family history. If you have a first-degree relative, parent, sibling, child with coeliac, your risk goes up considerably.
Stands to reason, given the genetics.
Exactly. And obviously having those HLA-DQ2 or DQ8 markers yourself is a major risk factor.
What about those other conditions you mentioned?
Yes, definitely. Having other autoimmune diseases puts you at higher risk. Think type 1 diabetes, autoimmune thyroid disease. Those are common associations. And certain genetic syndromes, too, like Down syndrome or Turner syndrome. People with these conditions have a higher prevalence of coeliac disease.
So doctors should probably be thinking about coeliac if they see patients of these things.
Absolutely. And NICE's, the National Institute for Health and Care Excellence, they actually brought out guidelines back in 2009. They recommend considering screening for coeliac in people with autoimmune thyroid disease, dermatitis herpetiformis, IBS in some cases, type 1 diabetes, and of course, those first-degree relatives.
Right. Being proactive makes sense.
Right.
Okay, let's get into the nitty-gritty, the pathophysiology. What's happening biologically?
Okay, so fundamentally, it's that abnormal immune response to gluten we talked about. This kicks off inflammation in the small intestine lining.
And specific immune cells are involved.
Yeah, key players are gluten-specific T cells. They recognize bits of gluten, and then the body produces antibodies like anti-tissue transglutaminase, TTG, and anti-endomeasial antibodies, EMA.
So these antibodies are like markers of the attack.
Kind of, yeah. They're part of the process that leads to the damage. The ongoing inflammation driven by these cells and antibodies is what causes that villous atrophy, the flattening of the villi.
And that directly impacts nutrient absorption.
Precisely. Less surface area means less absorption. The exact mechanisms are still being worked out, but the result is malabsorption. And again, underpinning this is that genetic susceptibility, those HLA-DQ2, DQ8 genes, making the immune system more likely to react this way.
It really highlights that genetic link. You mentioned family history before.
Yeah, the familial tendency is strong. About 10–15% of first-degree relatives might develop it. And in identical twins, the concordance rate is really high, maybe around 70%.
Wow, that's significant. So that HLA typing test you mentioned, how is it used?
It can be useful. It can help assess risk in family members. If someone tests negative for both DQ2 and DQ8, it makes celiac extremely unlikely for them. It's sometimes used in tricky diagnostic cases, too.
Okay. Now, coeliac symptoms can be all over the place. So are there other conditions that look similar to differential diagnoses?
Very important point. Yes, lots of things can cause similar symptoms, especially things causing malabsorption. You need to think about IBD inflammatory bowel disease like Crohn's or ulcerative colitis.
Right.
Also, IBS irritable bowel syndrome, food intolerances like lactose intolerance, and just other general gut disorders.
What about non-coeliac gluten sensitivity? That seems to pop up a lot.
Yeah, that's a distinct thing. People with non-coeliac gluten sensitivity get symptoms when they eat gluten and feel better off it, but, and this is key, they don't have the same autoimmune reaction or the gut damage seen in coeliac disease.
So no villous atrophy.
Correct. And there aren't specific blood tests for it either. It's more about ruling out coeliac and wheat allergy and seeing if symptoms improve on a gluten-free diet. Important distinction.
Okay. So how common is coeliac disease in the UK population overall? The epidemiology.
We said about 1% overall, but the big thing here is that many people are thought to be undiagnosed.
Really? Why is that?
Well, probably a few reasons. The symptoms can be super varied, sometimes quite vague, not always screaming gut problem. Awareness wasn't always great, though it's much better now. And diagnostic tests have improved. We have seen prevalence increase over the last 50 years or so, but a lot of that is likely better diagnosis and screening those high-risk groups we talked about.
Yeah.
Still, there's likely an iceberg of undiagnosed cases out there.
Right. So let's talk about those varied symptoms. How does coeliac disease actually present the clinical features?
It really is a mixed bag. You get the sort of classic gut symptoms, chronic diarrhea, maybe intermittent tummy pain, bloating, unexplained weight loss.
But it's not just gut stuff, is it?
Not at all. Fatigue is huge, really
Yeah.
common. Anemia, often iron deficiency anemia that doesn't respond to iron tablets. That skin rash, dermatitis herpetiformis, and neurological issues too.
Neurological. Like what?
Things like peripheral neuropathy tingling, numbness in hands and feet, ataxia, which affects balance and coordination. Some people, especially adults diagnosed later, might have quite subtle symptoms, or maybe just one main symptom like anemia.
It's a real chameleon. Is there a way to remember the key ones?
Yeah, we could try a mnemonic. How about digest fat in?
Okay, digest fat in. Break it down for us.
Sure. D for diarrhea, I for iron deficiency anemia, G for growth failure in kids, E for explained or unexplained GI symptoms, persistent ones, S for stomach pain, cramps, bloating, T for tiredness, prolonged fatigue, then F for faltering growth, again highlighting kids, A for anemia, other types too, T for tingling numbness, and N for other neurological symptoms.
Digest fat in. That's quite helpful, actually. Captures the range. So if someone comes in with these kinds of things, what investigations are done?
Diagnosis usually involves two main steps. Serological tests, those are blood tests for antibodies, and usually a small bowel biopsy.
The blood tests look for those antibodies you mentioned earlier, TTG and EMA.
Exactly. The first one we usually do is IgA TTG tissue transglutaminase antibodies. If that's maybe weakly positive, we might add IgA EM endomycel antibodies.
What if someone's IgA deficient? Does that affect the tests?
Good point. Yes, some people lack IgA antibodies generally. In that case, the IgA tests won't be reliable, so you'd look at IgG-based tests like IgEMA, IgGGP, deaminated gliadin peptide, or IgG-TTG.
And the genetic testing, HLA, DQ2, DQ8, where does that fit in diagnosis?
It's not usually a first-line diagnostic test on its own, because lots of people without coeliac have the genes. But it's really good for ruling it out. If you don't have DQ2 or DQ8, it's highly unlikely you have coeliac. It can be useful in tricky cases or for family screening.
Okay, so blood tests give clues, but the biopsy has always been the confirmer, right? The gold standard.
Traditionally, yes. The endoscopic intestinal biopsy was considered the definitive test. You go in with a small camera, usually into the duodenum, the first part of the small intestine, and take tiny tissue samples.
And under the microscope, you look for that damage.
Exactly. Pathologists look for those classic signs. Villous atrophy, the flattened villi. Crypt hyperplasia, deepening glands between villi. Increased intraepithelial lymphocytes, immune cells in the lining, and inflammation in the layer underneath, the lamina propria.
You mentioned a rectal gluten challenge earlier. Is that common?
No, not really. It's more of a research tool, not standard clinical practice for diagnosis.
Okay. Are there any other sort of general tests that might be relevant?
Yeah, a full blood count, FBC, might show anemia, low iron, low folate. Liver function tests, LFTs, can sometimes show raised liver enzymes, but these often get better on a gluten-free diet. Occasionally, a small bowel barium study might be done, but usually more to look for other causes or complications.
Now, you mentioned something really interesting earlier, that maybe a biopsy isn't always needed now for adults.
Yes, that's a relatively recent change in guidelines. For some adults, if the picture is very clear, a diagnosis can potentially be made without a biopsy.
What's the criteria for that?
Generally, it's for adults under 55 with clear symptoms and really high levels of IgA, TTG antibodies in their blood, usually defined as more than 10 times the upper limit of normal. And typically, they also need a positive result on a second antibody test, like the EMA test.
It can make things quicker for some people. But crucially, if you do need a biopsy, you have to keep eating gluten beforehand.
Absolutely vital. If you stop gluten before the biopsy, the gut can start to heal, and the biopsy might look normal, leading to a misdiagnosis. You must stay on gluten until it's done.
And even with a no biopsy diagnosis, seeing a specialist is still important.
Yes, definitely. Referral to a gastroenterologist is key for confirmation, ongoing management, education, and making sure nothing else is going on.
Okay, so summing up referrals. If someone tests positive on bloods,
Positive serology in adults and young people means referral for endoscopic biopsy. Positive serology in children means referral to a pediatric gastroenterologist.
and if the blood tests are negative, but you still really suspect coeliac,
Still refer. If the clinical suspicion is high, they should see a gastro specialist for further assessment.
right. Okay, diagnosis covered. Let's move to management. What's the treatment?
It's actually quite simple in principle, though challenging in practice. The only effective treatment is a strict, lifelong, gluten-free diet.
Lifelong. That means cutting out all wheat, barley, rye forever.
Correct. And anything made from them or contaminated with them, it's a huge lifestyle change.
Sounds tough. Support must be crucial.
Absolutely essential. Patients need really good information, education about the diet, why it's important, the risks of not sticking to it. Linking them up with specialist dietitians is key, and patient support groups like Coeliac UK can be incredibly helpful.
What specific education do they need?
They need to know which foods contain gluten, obviously, but also how to spot hidden gluten in processed foods, sauces, medications sometimes. Understanding food labeling is vital. They need practical advice on cooking, avoiding cross-contamination in the kitchen, eating out safely, managing social situations, recipes, resources. It all helps.
And what about supplements, given the malabsorption issues?
Good question. They should always discuss supplements with their doctor or dietitian first. But yes, especially early on, supplements like calcium and vitamin D might be needed to correct deficiencies. Iron and folate, too, sometimes.
What about gluten-free oats? Are they okay?
That's a tricky one. Oats themselves don't contain gluten, but they're very often contaminated with wheat during growing and processing. So only specially produced, certified gluten-free oats should be considered. And even then, a small number of people with coeliac might still react to the protein in oats, avenin. So it needs careful introduction under guidance.
Okay. And how are people monitored long-term?
Regular follow-up is important. If symptoms persist despite a strict diet, they need reassessing, maybe check for accidental gluten intake or look for other conditions. Blood tests for antibodies are sometimes repeated to check they're coming down. An annual review is generally recommended.
What does that involve?
Checking weight, height in kids, asking about symptoms. Maybe repeating blood tests like FBC, LFTs, checking vitamin and mineral levels, calcium, B12, folate, ferritin. Depending on risk, a DXA scan for bone density might be considered, and access to a dietitian if needed.
You mentioned non-responsive and refractory coeliac earlier. How are they managed?
Right. So if someone isn't getting better on the diet, non-responsive, first steps are double-check the diagnosis was correct and really scrutinize the diet for hidden gluten, usually with a specialist dietitian. You also need to think about other conditions causing symptoms like IBS or lactose intolerance.
And refractory.
Refractory coeliac disease is when symptoms persist even after ruling out ongoing gluten exposure and other causes. These cases are complex and need referral to a specialist center. Sometimes medication like prednisolone, a steroid, might be used short-term to manage symptoms under specialist care.
Okay.
Yeah.
Is there a mnemonic for management principles?
Let's try management. How about making a gluten-free diet work? Food exclusion, needing education and support, getting extra tests regularly, monitoring, and treating non-responders thoughtfully. Management. Maybe a bit clunky, but hits the key points.
Making a great food exclusion, needing education, getting extra tests regularly, and treating non-responders thoughtfully.
Yeah, works. Okay, so prognosis, what's the outlook?
Generally, it's really good if the gluten-free diet is followed strictly. The gut lining heals, symptoms improve, nutritional deficiencies correct. Most people can live a normal, healthy life.
But there are potential long-term complications to be aware of.
Yes, particularly if diagnosis is delayed or the diet isn't strictly followed. These can include ongoing nutritional issues, bone problems, and a slightly increased risk of certain cancers. But crucially, these risks are significantly reduced with good management and dietary adherence.
Okay, let's touch on those complications specifically. What are the main ones? Nutrient deficiencies are common, especially initially iron, folate, sometimes B12, vitamin D. This can lead to anemia, fatigue. Bone health is a big one, osteoporosis or osteomalacia, due to poor calcium and vitamin D absorption. There's that slightly increased risk of certain cancers, particularly gastrointestinal ones like small bowel lymphoma, though it's still rare overall. Other things can include ulcerative jejunitis, rare gut inflammation, reduced spleen function, hyposplenism, anxiety, and depression.
And infertility.
Yes, untreated coeliac can affect fertility in both men and women, but this often improves dramatically once on a gluten-free diet. And in pregnancy, undiagnosed coeliac carries risks for the baby, so diagnosis and management are important.
You also mentioned compliance challenges, especially in teenagers.
Yeah, sticking to a strict diet can be really tough socially for adolescents. It requires a lot of support. And non-compliance isn't trivial. It carries real long-term risks like poor bone density, ongoing deficiencies, and that increased malignancy risk. Good compliance, on the other hand, can actually improve bone density over time.
Right, so adherence is key. Any final memory tip for the complications?
Okay, let's try complications. Can't optimize nutrition deficiencies. Bones lose density. Increased cancer risk. Adolescent troubles with diet, infertility issues possible, other autoimmune links, neurological symptoms, splenic dysfunction, complications.
Can't optimize nutrition, bones become liable, cancer's a threat, infertility is a stress, adolescent struggle, outcomes negative if uncontrolled. Yeah, that covers a lot.
Hopefully helpful.
Definitely. That's been a really thorough walkthrough. So for you, the learner, hopefully that gives you a really solid grasp of coeliac disease.
Yeah, the key takeaways really are it's autoimmune, triggered by gluten, damages the small intestine, causing malabsorption. And the absolute cornerstone of managing it and preventing problems is that lifelong, strict gluten-free diet.
And reflecting on all this, with prevalence seemingly rising, or at least diagnosis rising, and such varied symptoms, it does make you think, doesn't it? What role could wider screening play? Could it help catch cases earlier and improve long-term outcomes? Something to ponder.
It's a really important question. And just a reminder for anyone preparing for their MSRA exams, you can find more resources and revision materials at pathomsra.com and freemsra.com.
Great. Well, thank you for joining us on this deep dive. We'll catch you on the next one.